Squamous cell carcinoma is a highly variable malignancy. Its clinical behavior, specifically how fast it grows and how aggressively it spreads, is dictated heavily by its site of origin and its underlying cause. The standard drivers of the disease include prolonged ultraviolet radiation, states of chronic inflammation, systemic immunosuppression, and exposure to chemical carcinogens. This photograph shows a classic baseline presentation. We see a top-down view of a bald scalp exhibiting field cancerization. Decades of UV exposure have created multiple red, scaly actinic keratosis lesions, premalignant cellular changes distributed across a broad area of tissue. Compare that baseline to this striking morphological variant. This image displays a massive curved cutaneous horn, a dense keratotic lesion that can harbor squamous cell carcinoma at its base. Other patients might present with rare genetic conditions like Ferguson-Smith syndrome, which triggers multiple self-healing squamous cell tumors independent of sun exposure. The disease can also exploit localized trauma. Marjolins ulcer is a highly aggressive variant that develops deep within the compromised, poorly vascularized tissue of chronic scars and severe burns. Categorizing the exact etiology and subtype is the crucial first step for the surgical team. A uniform approach to all squamous cell carcinomas will inevitably result in overtreating a surface lesion or failing to contain a lethal invasive one. The primary metric for stratifying these tumors is their rate of metastases. This data establishes a sharp quantitative divide between low-risk and high-risk disease pathways. This vector chart illustrates that statistical divergence. On the left, standard low-risk cutaneous squamous cell carcinomas carry a metastases rate of approximately 2%. On the right, high-risk cases escalate rapidly, with metastatic spread occurring in up to 30% of patients. Oral cavity squamous cell carcinoma, or OCSCC, serves as the primary model for this high-risk behavior. It accounts for over 95% of all oral cavity cancers. Due to this high metastatic potential, managing OCSCC requires massive composite locoregional resections. Surgeons must excise wide margins of normal tissue alongside the primary tumor and proactively clear the surrounding lymph node basins. Survival in these high-risk cases relies heavily on an integrated triad of care: aggressive structural ablation, virtual planned reconstruction, and pathology-directed adjuvant therapy. Resecting a large T4-stage oral cavity tumor removes significant regional anatomy. These procedures create massive, complex defects that eliminate sections of the floor of the mouth, the underlying mandible, and the overlying skin simultaneously. Historically, reconstructing these defects was a reactive process performed while the patient was already open on the operating table. Shaping bone grafts by eye prolonged ischemia times for the harvested tissue and yielded highly variable aesthetic and functional outcomes. The clinical solution is predictive virtual surgical planning, or VSP. This protocol uses the patient's preoperative CT scan data to mathematically model the entire reconstruction before the first incision is made. This 4-panel render shows the virtual planning interface. The software calculates the exact mandible resection, overlaying a donor scapula bone to achieve precise shape matching. The digital blueprint defines exact geometric cutting planes, generating coordinates to manufacture physical, patient-specific cutting guides and reconstruction plates. By finalizing these dimensions in the software, the surgical team shifts the most complex spatial problem-solving out of the operating room, significantly reducing the duration and inherent risk of the physical surgery. To execute the plan, the surgical team turns to the donor site, the patient's back, to harvest a composite-free flap containing both the required soft tissue and the bone. This image demonstrates the clinical application. The white 3D printed cutting guide is placed over the preoperative markings, dictating the osseous and soft tissue harvest boundaries. The drill holes and etched cut lines lock instruments into precise trajectories, matching the virtual plan for the scapula. This photograph displays the fully harvested composite flap. The template remains attached, confirming the successful capture and precise shaping of both the bone and the supporting soft tissue vascular network. Executing this pre-planned geometry yields strict clinical benefits. Total operative time drops, tissue ischemia is minimized, exact bone contact promotes rapid healing. This process ensures the reconstructed jaw is an exact physical match for the preoperative digital plan. When a tumor involves the upper jaw or maxilla, the structural requirements shift. Following a maxillectomy, osteoid obturators are a traditional method for sealing the resulting defect, though they can result in inferior functional outcomes compared to true tissue reconstruction. A robust modern alternative utilizes zygomatic implant perforator, or ZIP flaps, which surgeons place immediately following the tumor ablation. This visual presents the postoperative result. On the left, the zygomatic implant perforates the soft tissue flap to restore dentition. On the right, the X-ray confirms long implant shafts anchored securely into dense, healthy zygoma bone, far above the surgical defect. In select low-level maxillectomy cases, this evolving implant technology provides rapid structural and functional rehabilitation, bypassing the need for highly complex bone flap harvests entirely. Once the physical tumor is excised and the anatomy is restored, focus moves to the pathology lab. The microscopic analysis of the resected tissue now dictates the patient's systemic treatment. The World Health Organization tumor grading system provides the pathological parameters. These metrics create a strict logic used to determine if the patient requires postoperative adjuvant radiotherapy. This decision matrix outlines the current consensus guidelines. A patient requires radiation therapy if their pathology report identifies one major criterion or a combination of two minor criteria. The minor criteria column includes surgical margins that are close, measuring between 1 and 4.9 millimeters. It also includes lymphovascular invasion, perineural invasion, the presence of multiple positive lymph nodes, a single node larger than 3 centimeters, or a T3 or T4 stage tumor. Adjuvant radiotherapy is never deployed based on subjective clinical feeling. It is a rigid protocol, triggered directly by observed cellular behavior at the surgical margins. When the highest risk markers are present, the protocol escalates from standard radiotherapy to concurrent cisplatin-based chemoradiotherapy. This specific escalation relies on data from the landmark RTOG 9501 and EORTC 22931 randomized trials, which defined the modern standard of care for high-risk patients. Returning to the matrix, those trials isolated the two major criteria that mandate concurrent chemoradiotherapy: positive surgical margins of less than 1 millimeter, or the presence of extranodal extension, where the cancer has broken through the capsule of a lymph node. Even with strict protocols, treatment failures occur. Some patients will present with recurrent or metastatic disease that is no longer amenable to salvage surgery or further radiation. For these patients, systemic immunotherapy has become a primary treatment option. Tumors frequently exploit the PD-1 and PD-L1 cellular pathway to evade immune surveillance. By deploying PD-1 inhibitors to block this interaction, clinicians are successfully prolonging survival in advanced cases. Successful management of advanced SCC integrates mechanical precision in the operating room with targeted molecular analysis in the pathology lab.